Good afternoon and welcome to OCTalk, the show dedicated to helping home health and hospice providers run compliant and successful agencies. OCTalk aims to bring you closer to reliable experts in home health and hospice and to share the latest news and information from the industry and from the Association of Home Care Coding and Compliance. I'm Jan Milliman, Director for OC, and I'm happy to be hosting today's program. This afternoon, we're looking at potentially preventable hospitalizations. And now I'd like to introduce our industry guests for this episode. We have two members of the OC Advisory Board on the call today. We have Sherri Parson, CEO of Infusion Health, and we have Kelly Kavanaugh, Independent Home Health and Hospice Consultant and owner of the OTB Group on the call today. Thanks for joining us today, ladies.
Well, thanks for having us.
You're welcome.
All right, let's go ahead and get the discussion started. Listeners, if you have any questions for our panelists today, please go ahead and ask them in the chat pane, and we'll try to get to as many of those as we can. Sherri and Kelly, I'll just turn things over to you and let me know when I need to advance the slides.
Okay, thanks, Jan. Thanks, everyone, for joining us today as we're going to talk about potentially preventable hospitalizations, or as you all know it, PPH. We are spending time talking today about PPH because what we're seeing are a lot more questions and concerns about this measure. There's more focus now since we are not only looking at our performance being measured for quality purposes, but we now need to look at the potential impact the PPH measure has on revenue in value-based purchasing if we don't perform well. Now, what we hear from a lot of organizations are they're very anxious about this measure because they feel they have no control on whether a patient is rehospitalized or not. And being scored in value-based purchasing seems overwhelming because they don't feel they have this control. So I felt that this quote from Jimmy Dean, even though he does breakfast sausage, might be a good reminder about what we should be thinking about when we're looking at PPH. You can control the direction of the wind, but you can adjust your sails to always reach your destination. So we can't control everything, but we can adjust. And I believe, and so does Kelly, that when we follow some specific strategies, we can perform well with that PPH measure. So in the next 30 minutes, we're going to first set up some background around the measure, and then we're going to spend the bulk of the time talking about what you can specifically do in your organization to improve your outcomes as an agency, and then ultimately those outcomes of your patients. So why this got CMS's attention to begin with is you can see some pretty staggering metrics here. So it is estimated that 17 to 20% of all those discharges from the hospital were readmitted within 30 days. Now, out of those, 76% of the readmits were potentially preventable if something was done differently. And all of these preventable hospitalizations represent a whopping, look at that number, $12 billion of unnecessary expenditures. Next slide, Jan. CMS had decided where to begin. They had to figure out, we've got to start somewhere with this. And so first they pulled together a technical expert panel made of different clinicians from all kinds of different settings within the healthcare industry. Now, this TEP was formed back in 2018 to accomplish a couple different things. First off, they had to define what was a potentially preventable hospitalization in home health. Next, they had to decide what risk factors influenced these diagnoses and what should be included and excluded from this measure. And finally, they wanted to make sure what this measure included was accurate for that unserved population as well. So underserved populations, those are those individuals with those social determinants of health. We're hearing a lot more about that these days and the effects that those variables have on health care setting outcomes. Next slide, please. The panel began by using data that was already in the healthcare industry. So there were a lot of settings that were already looking at acute care hospitalizations and analyzing the rehospitalization rate. This TEP group was able to begin to categorize and decide what types of diagnoses should be included in this measure for home health, and which of these diagnoses could result in hospitalizations that could be prevented if the home health agency took measures ahead of time. The PPH measure began to take form, and the technical expert panel was actually able to distinguish specific groups that really illustrated diagnoses within broad categories that, if steps were taken by home health agencies, could potentially prevent hospitalization of their patients. Now, what emerged was the following 4 categories: inadequately managed chronic conditions, inadequately managed infections, inadequate management of unplanned events, and then finally, inadequate prevention of injuries. We're going to drill down in a couple of the slides coming up on what specific diagnoses are represented in each of these categories. And then we're going to look at what we can do as agencies to prevent these hospitalizations. And Kelly's going to spend a lot of time giving us some real practical ways to do that. Next slide, please. When looking at the PPH measure, we need to understand what hospital admissions are counted. Is it all of them? For example, planned hospitalizations don't count for this measure. We are looking at unplanned events. One major difference from that acute hospitalization measure that we used to use is that was only for acute hospitalizations. When we're looking at this measure, it is acute hospital admissions, but it also includes those observation stays as well. Now, many of these on the call have probably been coding for a while like myself, and you probably had a similar experience to me. I remember all of a sudden I was wrestling with whether a patient was admitted or they were just on an extended observation stay, and even though the stays were over 24 hours, we couldn't be sure if they were actually a hospital admission or an observation stay. There was a definite increase in the number of observation stays I was seeing when I was reviewing charts. But what I didn't understand at the time was that there was a reason for this. At the time, hospitals were in a value-based purchasing model themselves and trying not to get dinged on their scores. So by avoiding hospital admissions and then placing their patients in observation stays, they would normally have been admissions, but they were placing them in those observation stays so they didn't get the score against them. So CMS caught on and identified that these numbers were being skewed by this practice, and what was potentially preventable by an organization to avoid hospital admissions really didn't vary from what sent that patient to the observation stay. So the technical panel decided for purposes of this measure, there was really no difference in the steps that a home health agency would take to prevent hospitalization or observation stay. Both would count for this measure. Next slide, please. So it's important as we look at what we can do differently to improve our scores as organizations that we understand specifically what diagnoses are triggering CMS. What do they have in mind? So we can take actionable, that's the word they use, actionable steps to prevent these hospitalizations. That first broad category, inadequate management of chronic diseases, contains these these main diagnosis groups. Adult asthma. Now I want you to realize that doesn't just include adult asthma. This is the broad category, but it also includes acute bronchitis, for example. When we're looking at CHF, it includes any type of heart failure, including rheumatic heart failure, as well as hypertensive chronic kidney disease and heart failure of any kind. So COPD group also includes chronic bronchitis, bronchiectasis, emphysema. When we're looking at diabetes short-term complications, it includes hypo, hyperglycemia, ketoacidosis, skin ulcers, dermatitis, oral complications, diabetic, arthropathy, and any type of diabetes that these complications are in. And then the final group under this chronic category is hypotension, which would also include your orthostatic hypotension and your hypertensive chronic kidney disease without that heart failure. So when you see all these diagnoses and you're looking at these, you're probably already thinking there are steps as agencies that you could take that would impact whether or not your patient went to the hospital. And again, Kelly's going to give us some real practical tools in a little bit. Next slide, please. So what about inadequate management of infection? What types of diagnoses are we looking at? Broad category. Bacterial pneumonia, but we need to understand that that really includes unspecified pneumonia as well. C. diff, we're looking at recurrent, we're looking at acute C. diff. If we're looking at influenza, we're looking at multiple types of influenza, the manifestations. But here's an interesting one, viral pneumonia is also captured here, as well as unspecified. UTI, not specified, cystitis, kidney infection, nephritis, renal, urethral abscesses, all of that is encompassed under that category. And then when we're looking at septicemia, we're looking at sepsis, severe, with or without shock. Next slide, please. So the panel began by using some data that was already out in the healthcare industry and analyzing a lot of this information. But, you know, one of the things that we found was that there was these unplanned events. And I always wondered what was included in these diagnoses. I always wondered what diagnosis would be included here. They include your pressure injuries, your acute kidney failure, arrhythmias, aspiration pneumonitis, dehydration, intestinal impaction. And again, I think if you think about these diagnoses, you can probably think if an agency takes steps or doesn't take steps, you could have some favorable or unfavorable outcomes for your patients. We don't have a slide for the inadequate injury prevention. It would have been too many diagnoses to include on that. But for example, we're looking at fractures due to falls. Those injuries, mostly head injuries and fractures that are resulting from falls. Now, I'm going to send this back to Kelly. Like I said, she's got a lot to cover here, a lot of practical ways that we can improve our performance so that hopefully we lower our anxiety as organizations. Kelly, take it away.
Okay, thank you so much, Sherri. That was great information on kind of where we've evolved and what we're going to be looking at going forward for 2025. And you know, it is a big deal. You know, it's been going on for a long time. It's just not really new. It's not something new that we're taking a look at, but it's becoming more of an emphasis. It's a bigger portion of our total performance scores, and it's becoming an urgent situation. So if you have not already taken steps to look at your hospitalizations, now would be past time to do that for sure. So like Sherri mentioned, there are a bunch of diagnoses that CMS is looking at specifically. So the most important thing or the best thing you could do, also take a look at your agency and look at those diagnoses. If you have a reporting structure within your EMR where you can run reports on patients with those diagnoses, that would be an excellent place to start to identify which of your patients would potentially be at risk for these kinds of hospital stays and get some things in place. There are lots of things you can do, which we're going to talk about in a minute, but there's a lot of things you can do to try to head off some issues with these patients. But the very first thing you need to do is identify which one of those patients, which one of your however many patients you have on service, which one of these are at risk and where do you need to focus your attention. So get with your EMRs if you can. If you don't know how to run reports, that would be a good place to gather that information. Pinpointing patterns with OASIS answers. Use your OASIS data. Again, running reports in your EMR if you have the ability to do so. But you've got some questions on the OASIS that you can identify risk with as well. Your 1033 question is all about hospitalization risk. So gather that information on your patients. Who has 4 or more of those items answered? That has been identified by CMS as being a risk. We get additional payment for those patients because of their risk of hospitalizations. So you need to know which of your patients on service currently have 4 or more of those items checked in 1033. The 1700s questions, those have been identified also as an indicator of your patients that may go in the hospital. They have issues with medications, those kinds of things that are very commonly involved in those hospital trips. Also, you want to, if you have a QAPI process, develop a performance improvement plan with insights to your own agency's hospitalization data. because you want to take a proactive approach to this. So it's an agency-wide performance issue that you're doing here with these hospitalizations and trying to prevent these hospital stays for your patients. So if you can get a proactive situation, you can also improve your outcomes as well on other areas of your performance. So it can be a win-win if you're looking at this from a global perspective within your agency. So some things that you can do more specifically now, we're going to talk about the little nuts and bolts pieces of things. Looking at your social determinants of health for sure. If your coding team within your agency is putting those codes on your plan of cares, you can a lot of times run reports on those as well. The use of those kinds of codes in those kinds of situations, that's very indicative of patients who end up in the hospital, and that could potentially be avoided as well. So talking with your staff is probably your number one best way to get some information across, but really looking at spotting and promptly reporting patient changes. So Jan, if you want to go to the next slide, this is something that an Superior Health, part of the Quality Alliance, they created this little tool here that you might be able to use. But these are some things, some physical and non-physical changes that you need to watch for with your patient population. So I would encourage you to use these kinds of tools with all of your staff, not just your nursing staff, but therapists, social workers, anybody who goes to your patients' homes, CNAs, everyone needs to know to watch for these kinds of changes and promptly spot them and report them to the case manager for your patient, because these kinds of things can oftentimes be precursors to something is happening or something is about to happen, and kind of a what's coming next would be the hospital stay. So you want to catch these kinds of things: falls, skin issues, subtle changes in their vital signs, increased weakness, their appetite's a little off, they're not sleeping as well as they usually do, maybe their mood is a little off, they're getting a little snippy with their caregivers. All those kinds of things could be some impending problems, something's about to happen. So watching for those subtle changes in the patient care. It would help in this case to catch these kinds of things, to have consistent staffing whenever possible. I know that there's staffing challenges, I understand what's going on in the industry, but this is a big deal for being able to catch these subtle changes in condition that could prevent the hospital stays, is having as consistent as possible your staffing in the home, so that they know that there's a change in Mrs. Smith from last week because it's the same clinician who saw the patient. If it's not possible to have consistent staffing, then you're gonna have to have really good documentation. If your staff is documenting well and thoroughly, and there's a place in your EMR where that some of these things can be quickly assessed or quickly seen by other caregivers. I know WellSky has the yellow sticky notes. I think there's a place for coordination notes in Home Care Home Base. So maybe doing some very specific types of notes where you could do a quick scan and where your clinicians can do a search by a certain type of note where they could see maybe the last information from the last clinician in the home, so that if you have changes in staff, they can identify those changes quickly in those patients' situation. Regular monitoring of your patients. I know everybody looks at frequency numbers and everybody's trying to cut back on the frequency of visits and things like that, but you know, the old 1 week 9 for nursing may or may not be the best frequency for your patient. If you identify that these patients are at risk for hospital stay, you know, maybe front loading some of those visits, get a few more visits in there, or you know the patient just had a med change, put a little extra nursing visit in there if you think that there could potentially be a problem with that situation. Patient just had a fall, you know, maybe they need an additional follow-up visit. Getting those extra pair of eyes in the home is probably gonna help save you money down the road, even though it may cost you a little bit more money putting that extra visit in there up front. But if you can avoid that hospital stay by making those visits, it would definitely pay off in the end. You can also use things like telehealth calls. Put some phone calls in place. If the patient just had a fall, do a follow-up phone call. Hey, how you doing? I know you fell, 2 days ago. Are you doing better? Have you fallen again? Doesn't necessarily have to be a visit. Maybe it's just a phone call. And there's ways to schedule those telehealth calls in there. They don't have to necessarily be anything official, but just something that there's a way to follow up with that. You may want to put some kind of reminder system, some kind of central calendar. Maybe there's an email inbox that everybody sends an email to this inbox that, hey, we need to follow up with this patient on Friday because they had a fall or they had a new med or they're, at risk. They had some swelling and we got to see if it's worse. So there's situations where it may not mean a visit, but definitely a touch point. Someone needs to be contacting that patient. Maybe it's somebody from the office. Maybe it's a CNA who just needs some extra work this week, that there's not a lot of patients. You can pull them into the office, maybe give them some office hours to make some touch point phone calls. So it's going to take some creativity to get some things in place to try to head off some of these hospital stays. Ensure that your patients are receiving clear discharge instructions when they are being discharged from your agency, because those post-discharge hospitalization stays are going to be an issue as well. So being sure that you're giving good discharge instructions to your patients when they're discharging from your service. Also, if we want, there we go. Next slide. You read my mind, Jan. Thank you. These are some things, these next tools, these are all tools for you on the different pain and CHF and COPD. There's some zone tools that have been created to identify when these patients may be becoming at risk. So you've got the green zone, everything's going good, people are rocking on, but then you start getting into that yellow zone. This is where you want to catch your patients. Do not let your patients get into the red zone, because then they're more than likely going to have to be hospitalized or going to go in the hospital. They're going to call 911. So the yellow zone is where your action area is. So if you are looking for identifying patients, identifying symptoms, the yellow zone on these tools are where you want to focus your efforts and concentrate on addressing these items, acting right away.
And I think, Kelly, if I can just jump in for a second, I think
Sure.
what I really like about the zone tools is that this is patient-centric. So the patient, you teach your patient to recognize it, because who's going to know before you get back in there, that patient? And if that patient can be invested in this, and this is where, like Kelly was talking about, those social determinants of health is really a big deal, because we have to meet our patients where they are at. We want to disseminate this information, but it has to be so that they can understand it. And you can see there, call your healthcare provider, having your number in there, making sure this is on your patient's fridge, and that they know how to use the tool is really going to make all the difference.
Absolutely. That was what I was going to say. The call us first. No, you're fine. You're fine. It just shows we're on the same page. Yeah. The call us first programs. I've heard several agencies kind of have that or something similar along those lines, that call us first, to try to encourage the patients to identify their own symptoms and to know to call the nurse or to call the home care agency, instead of trying to get a hold of their doctor and get frustrated because nobody's calling them back, and then they end up just calling 911 and going to the hospital. But that takes trust. You gotta get that patient's trust too. So if your patients are calling when they have symptoms, then you need to kind of reinforce that behavior, and they don't need to be, put on hold for 30 minutes or, ignored or not called back, because then they won't trust you and they won't call you first. So it's kind of a double-edged sword. If you put that into place, then you need to be sure that your on-call staff are aware, that they're responding appropriately when those patients call with this type of information, that they don't get blown off when they call in. So because it is a trust-based situation, they have to trust that you're going to handle the information that they give you appropriately. So be sure that everyone in your organization understands your program and why you're doing it. So, but yes, this would be a great tools for patients and family members to be able to know what to watch for. So, okay, next slide. So these are all just similar. This one is the one for COPD, But same concept. Got the green zone when everything is good. It's got the yellow zone when things are starting to unravel. This is your action items. These are the things your patients need to know to watch for, your caregivers need to know to watch for, your staff needs to know to watch for, and your on-call staff need to know when patients call in with these symptoms that is something that they need to jump on, and get somebody out there and get some education going to these patients so that you can prevent them from going into the red zone, because that's when those hospitalizations are gonna take place. Next slide. And this is the zone tool for the CHF or heart related conditions. Same concept. You've got the green there at the top. Everything's good. Continue going forward. The yellow is your pay attention, use caution, watch out for these things, put some things in place, get some symptom management going, calling doctors, making med changes, making sure they're med compliant, all those kinds of things to pay attention to in that yellow zone and to prevent them going into the red there again. Next slide, I think, yep. Next slide is the reference page. So this is where we've come up with all of our information mainly, but just thinking outside the box. Like I said, just identifying those patients that are most at risk. What can your agency organization as a whole do to work together to try to put some things in place that can prevent these patients from going into those red zones and having issues with all those chronic conditions and all the items that CMS has identified for us, the infections and the chronic conditions, injuries, all those things that they identified. Those are where we definitely need to be paying attention on those patients. So it's a global look, and it takes, your whole organization working together to try to prevent these situations from happening.
Thanks, Kelly and Sherri. This was great. Lots of good information. I think those patient tools are so helpful, I'm sure, with helping people know what to do when things start to go off the rails. So great stuff. Thank you both.
Mm-hmm.
All right, now it's time for our product spotlight. If you're looking for a way to keep up to date with the issues that impact the industry, consider a subscription to Home Healthline. This weekly publication brings you home health specific news, analysis, guidance, and specific tools that can help you to increase referrals and profitability during times of increased competition and regulatory scrutiny. And AHC members receive a 15% discount on Home Healthline subscriptions, so click through the link in your handouts to start your subscription today. And it's also time for What's New with AHC, where we share updates from the Association of Home Care Coding and Compliance. And we wanted to let you know that there is still time to take the Home Health Coders Documentations Practices survey. Here at AHC, the concern we hear about the most often is issues with documentation, inadequate documentation, confusing documentation, and we want to make sure that we're creating tools and resources that might help you with this issue. So we've created this brief survey to kind of take the pulse of how folks are approaching documentation in home health. And if you could follow this link, if you haven't already, and take the survey, it's in your handouts. It would be a great help to us in making future plans. And feel free to share that link with your colleagues. They don't have to be AHC members. The more information we can gather on this topic, the better. And if you're listening to a podcast version of this show, you'll find the handouts on the AHC website along with the recording under resources and free webinars, and then click on download and that'll get you to the handouts. We hope you enjoyed this episode of AHC Talk. Thanks again to Sherri and Kelly for all the great information, and thanks to all of you for tuning in. We hope you'll join us again for our February call when we'll be talking about face-to-face. And in the meantime, if you'd like to re-listen to this episode or a previous one on the go, you can now find AHC Talk on your favorite podcast app, or you can listen to the recording and access those handouts on the AHC website. And if you have any suggestions for future guests, topics, or ideas about the format of the show, please send me an email at jan.milliman@decisionhealth.com. Thanks so much for listening, and we'll see you next month. Take care, everybody.